Chapter 13, Point-of-Use Disinfection and Sterilization. Welcome to the comprehensive audio study guide for Chapter 13, focusing on point-of-use disinfection and sterilization. This chapter represents a critical juncture in your professional development as a sterile processing technician. We are moving away from the centralized, controlled environment of the decontamination and sterilization departments and stepping into the high-pressure, time-sensitive reality of the procedure room and operating suite. This area of study is vital not only for your certification exam but also for patient safety, as the practices discussed here involve high risks if not executed with perfect precision. Let us begin with the fundamental concept and definition of point-of-use processing. In the context of sterile processing, point-of-use, often abbreviated as POU, refers to the cleaning, disinfection, or sterilization of medical devices that occurs immediately before they are used. This activity typically takes place within the procedure room itself or in a substerile room located directly between operating suites. It is essential to understand that this is a departure from the standard workflow. The gold standard for reprocessing medical devices is always terminal sterilization within the central sterile processing department. The central department provides a controlled environment, specialized high-capacity equipment, and, most importantly, sufficient time to ensure every step of the process is validated. However, the reality of healthcare is that emergencies happen, and clinical situations arise where the standard workflow is impossible. For example, imagine a scenario where a unique, one-of-a-kind instrument is dropped on the floor during a critical spinal surgery. If there is no sterile backup available and the surgery cannot proceed without that specific instrument, the surgical team cannot wait several hours for a full terminal sterilization cycle. In this specific instance, the instrument must be processed immediately at the point of use to allow the surgery to continue safely. This brings us to the most critical distinction you must memorize. The difference between terminal sterilization and point-of-use sterilization is storage. Items processed via terminal sterilization are wrapped or packaged to maintain sterility for a specific shelf life, allowing them to be stored for later use. In sharp contrast, items processed at the point of use are intended for immediate use only. They are not packaged for shelf life, and they cannot be stored. Even placing a point-of-use processed item on a shelf for a few minutes constitutes storage and is a violation of protocol. Now, we must address the primary method used for this process, immediate use steam sterilization, or IUSS. IUSS is formally defined as the steam sterilization of medical devices for immediate use. You will likely encounter veteran staff who still refer to this process as flash sterilization. It is imperative that you understand the history and current status of this terminology. Historically, this process was indeed called flash sterilization. However, leading organizations such as the Association for the Advancement of Medical Instrumentation, known as AAMI, and the Association of Perioperative Registered Nurses, known as AORN, have officially retired this term. The word flash implied a shortcut, a rushed job, or a process that was somehow less effective than standard sterilization. The shift to the terminology IUSS is deliberate and significant. It emphasizes that the sterilization process itself involves the exact same critical parameters as terminal sterilization. The steam must reach the same temperature, the pressure must be identical, and the exposure time must be sufficient to kill microorganisms. The only technical difference in the cycle is the lack of a drying phase, which allows for rapid turnaround. By using the term IUSS, we reinforce the mindset that we are not taking shortcuts on safety, we are simply eliminating the storage capability to meet an urgent medical need. This leads us directly into the standards and recommended practices that govern IUSS. Because IUSS bypasses the controlled environment of the central department, it is subject to rigorous standards to prevent abuse. AAMI and AORN have established clear guidelines stating that IUSS should only be used in urgent clinical situations where there is insufficient time to process the instrument through a preferred wrapped method. It is a violation of these standards to use IUSS for inventory management issues. For instance, if a hospital refuses to purchase enough surgical trays to cover their case volume, and staff are forced to use IUSS daily to turn over sets between cases, this is a breach of standards. IUSS is designed for emergencies, not for convenience or to compensate for a lack of equipment. Crucially, standards also dictate who can perform these tasks. Staff members performing IUSS must demonstrate specific competency. It is not enough to simply be present in the operating room. The technician must undergo documented training on the specific sterilizer model, the cleaning protocols, and the safety measures required. This training must be verified and recorded by the facility to ensure that only qualified personnel are making these critical decisions. Compliance with these standards is enforced by surveying agencies. Organizations such as the Joint Commission, often referred to as TJC, and the Centers for Medicare and Medicaid Services, or CMS, aggressively monitor IUSS practices during their accreditation surveys. These surveyors review sterilization logs with a critical eye. They look for high rates of IUSS usage, which serves as a red flag indicating poor inventory management or insufficient instrumentation. They also scrutinize documentation to ensure that every instance of IUSS was tied to a specific patient and a specific urgent need. If a facility cannot justify its use of IUSS, or if the logs show a pattern of routine use, the facility risks being cited for non-compliance, which can threaten their accreditation and ability to operate. Therefore, understanding the role of these surveying agencies is not just about passing an exam, it is about protecting your facility's reputation and legal standing. Building upon the regulatory foundation of immediate use steam sterilization, we must now confront the single most important operational rule of this entire chapter, the no shortcuts rule regarding cleaning and decontamination. There is often a misconception that because IUSS is an expedited process, every step of the workflow can be rushed. This is dangerous and incorrect. We must be crystal clear that the immediate nature of IUSS applies strictly to the sterilization cycle itself, specifically the omission of the drying time. It absolutely does not apply to the pre-cleaning steps. The certification exam frequently tests this concept to ensure technicians understand that if an item is not clean, it cannot be sterile. Steam sterilization relies on the direct contact of steam with the surface of the instrument. Steam cannot penetrate soil such as blood, bone, tissue, or other organic debris. If these contaminants remain on the device, the bacteria hidden beneath that soil will survive the sterilization cycle, regardless of how hot the chamber gets. Therefore, to perform IUSS safely, you must strictly adhere to the manufacturer's instructions for use, IFU, regarding decontamination. This process begins by taking the contaminated item to a designated decontamination area that is equipped with a proper sink. You must manually clean the item with water and an appropriate detergent, brush the lumens and crevices to remove visible soil, and thoroughly rinse the device. Skipping this decontamination step or simply rinsing the instrument with saline in the operating room renders the entire IUSS cycle ineffective and unsafe. Furthermore, the instruments must be properly prepared for steam penetration. This means disassembling multi-part devices and unlatching all box locks so that steam can contact every surface. Once the items are thoroughly cleaned and inspected, they are ready for the sterilization cycle. For the purposes of your exam and daily practice, you must be familiar with the specific cycle parameters used for IUSS. These cycles can be performed using either gravity displacement sterilizers or dynamic air removal sterilizers, also known as pre-vacuum sterilizers. The specific exposure times and temperatures will always depend heavily on the manufacturer's written instructions, and you should never guess. However, there are standard parameters found in AAMI guidelines that you are expected to know. For dynamic air removal cycles, which utilize a vacuum pump to rapidly remove air from the chamber, the typical sterilization temperature is set at either 270 degrees Fahrenheit or 275 degrees Fahrenheit. In Celsius, this range is approximately 132 to 135 degrees. The exposure time for this cycle is typically 3 minutes or 4 minutes, depending on the composition of the load, such as whether it contains only metal instruments or a mix of porous and non-porous materials. This pre-vacuum cycle is the most common method used for IUSS in modern facilities because of its efficiency. Alternatively, you may encounter gravity displacement cycles, which rely on the natural properties of steam to displace air. Because this method is less efficient at air removal, it requires longer exposure times. The typical temperature for a gravity IUSS cycle is 270 degrees Fahrenheit, or 132 degrees Celsius. If you are processing non-porous items, such as simple metal instruments without lumens, the exposure time is generally 3 minutes. However, if the load includes porous items, such as rubber or mixed materials, the exposure time must be increased significantly to 10 minutes to ensure proper lethality. The defining technical characteristic that separates these IUSS cycles from terminal sterilization is the drying phase. In a standard terminal cycle, the drying phase can last 30 minutes or more to ensure the pack is completely dry for storage. In an IUSS cycle, there is little to no drying time, usually less than 1 minute. This has a profound physical result. Items removed from an IUSS cycle are hot and wet. This moisture presents a major risk because it can act as a vehicle for bacteria. This phenomenon, known as wicking, allows bacteria from unsterile surfaces like gloves or tables to travel through the moisture and contaminate the instrument. This reality makes the transport and handling of IUSS items a high-risk activity that requires specific containment protocols. Since we have established that instruments emerging from an immediate-use steam sterilization cycle are hot and wet, we must address the immediate challenge of protecting them from contamination. The presence of moisture on a hot instrument acts as a magnet for bacteria, creating a pathway for microorganisms to migrate from unsterile surfaces to the critical device. This vulnerability dictates the strict protocols for safe transport. The days of carrying an open tray through a hallway or covering instruments with a simple paper or cloth towel are over. These methods do not provide an adequate microbial barrier and are strictly prohibited. To ensure aseptic transport, items processed via IUSS must be placed in a rigid container or tray that is specifically designed and validated for this purpose. In the field, you will often hear these referred to as flash pans. It is critical to note that these containers themselves must be cleaned and inspected between uses according to the manufacturer's instructions. A dirty container will contaminate the clean instruments inside. These containers are engineered with mesh bottoms or open vents that allow for the rapid removal of air and the penetration of steam during the cycle. Crucially, they typically feature specialized valves or filter mechanisms that automatically open during the sterilization process and close immediately afterward to seal the container. This design ensures that the instruments remain protected from airborne contaminants during the short journey from the sterilizer to the surgical field. The physical act of transport requires equal attention to safety and technique. Because the metal container and the instruments inside are extremely hot, personnel must wear clean, heat-resistant gloves to prevent burns. The transport path must be direct and controlled. The item must be moved immediately to the sterile field without touching non-sterile surfaces, passing through general corridors, or entering high-traffic areas. The rigid container provides the necessary protection during this transit, but it is not a storage device. Once the container reaches the sterile field, it is opened, and the instruments are used immediately. Beyond the logistical rules of transport, there are specific categories of devices and biological hazards that are strictly prohibited from IUSS processing, regardless of the emergency. You must memorize these for the exam. The first major prohibition involves prion. Prion are abnormal, pathogenic agents that are transmissible and are specifically associated with Creutzfeldt-Jakob disease, or CJD. Prion are exceptionally resistant to standard sterilization parameters. Because IUSS cycles are abbreviated and often lack the extended exposure times required to neutralize these agents, IUSS is generally not effective and is not allowed for instruments potentially contaminated with prion. The second critical prohibition concerns single-use devices. As the name implies, these devices are manufactured and validated for one-time use only. They are often made of materials that degrade after a single exposure to heat or chemicals, and their designs may include crevices that are impossible to clean. Consequently, manufacturers do not provide instructions for reprocessing them. You cannot use IUSS to reprocess single-use devices under any circumstances. Doing so violates federal regulations and places the patient at significant risk of infection or device failure. These prohibitions reinforce the principle that IUSS is a specialized tool for specific emergencies, not a universal solution for all instrument needs. Having defined the strict prohibitions regarding prion and single-use devices, we now arrive at perhaps the most frequently tested and clinically significant topic in point-of-use processing: the rules regarding implants. To navigate this correctly, we must first establish the technical definition of an implant. According to FDA and AAMI standards, an implant is defined as an object placed in a surgically created or naturally occurring cavity of the body that is intended to remain there for a period of 30 days or more. Common examples you will encounter in the operating room include orthopedic screws, metal plates, and total joint replacement components. The general rule for these devices is straightforward and rigid: immediate use steam sterilization should not be used for implantable devices. Leading organizations, including AAMI and AORN, strongly recommend against this practice. The logic is sound. Placing a foreign body inside a patient permanently creates a high risk for infection. If that device is not sterile, bacteria can form a biofilm on the implant surface, leading to deep-seated infections that often require a second surgery to remove the hardware. Therefore, carefully planned inventory management should always ensure that sterile, packaged implants are available, rendering point-of-use processing unnecessary. However, clinical reality dictates that exceptions must exist. IUSS may be used for implants only in a documented emergency situation where no other option is available. For example, if a specific size of screw is dropped and it is the only one that fits the patient's anatomy, the surgery cannot proceed without it. In this rare instance, you may proceed, but strict monitoring requirements immediately kick in. You are required to run a biological indicator, or BI, and a Class 5 chemical integrator with a specific load containing the implant. The Class 5 integrator provides an immediate visual check that critical parameters were met, but it is not enough on its own. The most critical component of this protocol is the quarantine rule. If an implant is processed via IUSS, it should not be released for use until the biological indicator result is known. This is a massive logistical commitment. It means the surgical team must wait, with the patient often under anesthesia, until the BI test confirms that the spores have been killed. To make this feasible, facilities utilize rapid readout biological indicators, which can provide a result in a significantly shorter time frame compared to standard BIs. Only after the rapid readout BI returns a negative result, confirming that the sterilization conditions were lethal to the test spores, can the implant be released to the sterile field. This ensures that we never knowingly place a non-sterile foreign body inside a patient, even in an emergency. Because immediate use steam sterilization occurs outside the standard tracking loops of the Central Sterile Processing Department, the documentation requirements must be even more rigorous to ensure full traceability. If a patient develops a surgical site infection days or weeks after a procedure, the facility must be able to prove, with absolute certainty, that the instrument used on them was processed correctly. To achieve this, keeping a detailed IUSS log is mandatory. This log must contain 6 specific data points for every single cycle run. First, you must record the patient information, specifically the patient name and medical record number. This provides the critical link between the cycle and the specific surgery. Second, you must record the instrument identification, which includes the specific name or serial number of the device sterilized. Third, you must document the cycle parameters, specifically the temperature and exposure time used, to confirm they met the manufacturer's instructions for use. Fourth, and perhaps most scrutinized by surveyors, is the reason for IUSS. You must document exactly why IUSS was performed, such as one-of-a-kind instrument dropped. This creates an audit trail proving that the cycle was a genuine emergency and not a result of routine convenience. Fifth, you must include cleaning verification, a signed confirmation that the item was thoroughly decontaminated prior to sterilization. Finally, you must record the monitoring results, indicating whether the chemical and physical monitors passed. Beyond the paperwork, the physical process relies on strict quality control monitors. You cannot skip these steps just because you are in a hurry. Every cycle produces a physical monitor record, typically a printer tape or a digital readout. At the end of every cycle, the operator must review this record to verify that the chamber reached the correct temperature, such as 270 degrees Fahrenheit, and held it for the required exposure time. The operator must then sign or initial the tape to formally document this verification. Inside the container, chemical indicators, or CIs, provide the next layer of assurance. A Class 5 integrating indicator or a Class 6 emulating indicator must be placed inside every container or tray. A Class 5 integrator is particularly important because it reacts to all critical variables of the sterilization process, including time, temperature, and the presence of steam, and its response correlates to a biological kill. If the integrator does not reach its accept window, the tray is not sterile and cannot be used. Finally, we must address the routine testing of the equipment itself using biological indicators. While implants require a BI with every load, the sterilizer itself must be monitored routinely to ensure it is functioning correctly. For sterilizers dedicated to IUSS, a biological indicator should be run at least weekly, though best practice and many facility policies prefer daily testing. This routine testing confirms that the sterilizer is capable of killing highly resistant bacterial spores. If a routine BI test fails, the sterilizer must be taken out of service immediately until the cause of the failure is identified and corrected. We now pivot from the high-temperature world of steam sterilization to the processing of heat-sensitive devices. In the modern operating room, technicians frequently encounter delicate instruments that simply cannot withstand the 270-degree heat or the intense moisture associated with steam sterilization. These devices, which include flexible endoscopes, rigid fiber optic scopes, and sensitive surgical cameras, require alternative processing methods if they must be turned over rapidly for urgent use. Just like immediate use steam sterilization, processing these heat-sensitive items at the point of use is intended strictly for emergency situations. It is never a substitute for having an adequate inventory of scopes or cameras. The decision to process these items outside of the centralized sterile processing department should always be driven by a critical patient need and the lack of other sterile options. When dealing with heat-sensitive devices at the point of use, there are two primary methodologies available: high-level disinfection, known as HLD, and liquid chemical sterilization, known as LCS. It is vital to understand the difference in lethality between these two. High-level disinfection is the minimum standard for devices classified as semi-critical. Recall that semi-critical devices are those that come into contact with mucous membranes or non-intact skin. The HLD process is designed to kill all vegetative bacteria, viruses, and fungi. However, it does not necessarily kill high numbers of bacterial spores. Common chemical agents used for this process include glutaraldehyde and orthothialdehyde, which is commonly referred to in the industry as OPA. Historically, HLD was performed by manually soaking instruments in basins filled with these chemicals. However, current standards and best practices strongly recommend, and in some cases mandate, the use of automated endoscope reprocessors, or AERs. Automated systems provide a level of safety and consistency that manual soaking cannot achieve. An AER guarantees that the chemical stays in contact with the device for the exact required time, at the correct temperature, and provides a validated rinsing cycle to remove toxic residues. It is critical that this final rinse uses treated, filtered, or sterile water. Using plain tap water can recontaminate the high-level disinfected device with waterborne bacteria, defeating the purpose of the process. Crucially, you must verify the potency of these chemicals before use. This is done through minimum effective concentration, or MECT, testing. You must use a test strip specific to the chemical you are using to confirm that the solution is still strong enough to kill microorganisms. This test must be performed before each and every patient use. If the solution fails the MECT test, it must be discarded immediately, even if the expiration date on the bottle has not yet passed. The second methodology is liquid chemical sterilization, or LCS. This is a significant step up from disinfection. LCS uses potent liquid sterilants, such as peracetic acid, to eliminate all forms of microbial life, including highly resistant bacterial spores. Systems like the Stera System 1E are frequently used for this specific purpose. However, LCS has a critical operational constraint that you must remember: it is a just-in-time solution. The outcome of a liquid chemical sterilization cycle is a wet device. Because the device is wet and not packaged, it has no shelf life and cannot be stored. It must be transported aseptically to the sterile field and used immediately. If there is any delay, or if the device is placed in storage, it is considered contaminated and must be reprocessed. Effective sterilization and disinfection are entirely dependent on how the device is prepared before it enters the chamber or processor. The preparation protocols for low-temperature processing mirror steam sterilization in one vital aspect: the absolute necessity of cleaning. Just as with steam, the device must be thoroughly cleaned, brushed, and rinsed before any processing can occur. If an item is not clean, the sterilant or disinfectant acts only on the surface soil and cannot reach the device surface itself. The process will fail, and the device will remain contaminated. However, once cleaning is complete, the protocols for drying differ significantly depending on the method you are using. For hydrogen peroxide gas plasma or vaporized hydrogen peroxide systems, the device must be completely dry before processing. Moisture is the enemy of these technologies. Even a small amount of residual water on the surface of an instrument or inside a lumen will cause the sterilization cycle to abort or cancel. This is because water interferes with the physics of the hydrogen peroxide plasma process, preventing the system from reaching the necessary concentration. Therefore, technicians must meticulously dry every part of the device using lint-free cloths and medical-grade air. In stark contrast, when preparing devices for liquid chemical sterilization, or LCS, the drying requirement is often less stringent. Because the sterilant itself is a liquid solution, the device generally can be wet when placed into the processor trays. The presence of rinse water does not typically cause the cycle to fail in the same way it does with vapor systems. However, you must always consult the specific manufacturer's instructions, as excessive water could potentially dilute the chemical sterilant below its effective concentration. Material compatibility extends beyond just moisture. We must also address lubrication. You cannot assume that the standard instrument milk or lubricants used for steam sterilization are safe for low-temperature processes. Standard oil-based lubricants, particularly those containing mineral oil, can be disastrous in this environment. The oil can coat microorganisms, effectively creating a shield that the low-temperature sterilant cannot penetrate, leading to cycle failure and non-sterile instruments. You must only use lubricants that are specifically tested and approved by the sterilizer manufacturer for that specific cycle. Finally, you must be aware of material prohibitions within the chamber itself. For hydrogen peroxide gas plasma systems, cellulose-based items are strictly prohibited. This means you cannot put paper count sheets, cotton towels, or paper plastic pouches into the load. Cellulose acts like a sponge, absorbing the sterilant and preventing it from sterilizing the instruments. Additionally, liquids and powders are generally not compatible with these vacuum-based systems and should never be placed in the chamber. Understanding these specific limitations is key to preventing costly cycle cancellations and equipment damage. The chemicals used for high-level disinfection and liquid sterilization are effective precisely because they are potent biocides. However, this same potency makes them hazardous to human health. Agents such as glutaraldehyde and OPA are known irritants and can cause significant respiratory and skin issues if handled improperly. Therefore, unlike steam sterilizers which primarily pose burn hazards, point-of-use areas utilizing liquid chemicals must have specific engineering controls in place to protect staff. The most critical engineering control is ventilation. Areas where these chemicals are used must be equipped with dedicated exhaust hoods that pull fumes away from the technician's breathing zone. If a dedicated hood is not available, the room itself must meet strict air exchange requirements to dilute potential vapors. The standard requirement is a minimum of 10 air exchanges per hour. Furthermore, this exhaust should be vented directly to the outside of the building, rather than recirculated into the general hospital air conditioning system. This ensures that toxic fumes are removed from the environment entirely. Personal protective equipment, or PPE, is the second line of defense. Standard latex exam gloves are often insufficient for handling these aggressive chemicals. Technicians must wear chemical-resistant gloves, typically made of nitrile or butyl rubber, which are specifically rated to withstand the sterilant being used. In addition to gloves, full face shields or splash goggles are mandatory to protect the eyes from accidental splashes during pouring or rinsing. A fluid-resistant gown should also be worn to protect skin and clothing. You must also be vigilant about date marking for these chemicals. Unlike standard supplies, liquid sterilants and disinfectants typically have two important dates. There is the expiration date stamped on the bottle by the manufacturer, and a separate use life date that begins once the bottle is opened or the solution is activated. You must write the date of opening and the new expiration date on the container. The solution expires on whichever of these two dates comes first. Finally, accidents happen, and facilities must be prepared for them. Spill kits containing neutralizing agents must be readily available in the immediate area. These agents are formulated to chemically deactivate the specific sterilant or disinfectant in use, turning it into a less hazardous substance that can be safely cleaned up. Staff must be trained not just on how to use the chemicals for sterilization, but specifically on how to contain and neutralize a spill should one occur. We have now reached the conclusion of Chapter 13. Throughout this study, we have examined the high-stakes environment of point-of-use processing. Whether utilizing high-temperature steam in an immediate-use steam sterilizer or employing toxic chemicals for heat-sensitive devices, the underlying principle remains the same. Point-of-use processing is a vital safety net designed strictly for surgical emergencies. It is a tool to save a life when no other option exists, but it is never a substitute for proper inventory management or the gold standard of terminal sterilization in the central department. As you prepare for your certification exam and your career, lock these 4 core takeaways into your mind. First, cleaning is non-negotiable. You cannot sterilize a dirty instrument. If you skip the decontamination step, you are merely baking soil onto the device and ensuring that bacteria survive. Second, there is absolutely no storage allowed. Items processed at the point of use are hot, wet, or chemically treated for immediate need. They must be used instantly or reprocessed. Third, documentation must be flawless. Every cycle must be traceable to the specific patient, with clear proof that cleaning occurred and parameters were met. And finally, respect the rules regarding implants. Avoid using IUSS for implants unless it is a dire emergency, and if you must, always use a biological indicator and quarantine the load until the result is negative. When performed correctly, with strict adherence to these standards, point-of-use processing saves lives. When abused for convenience or rushed without care, it endangers them. Carry this responsibility with you in every decision you make. This concludes our study of Chapter 13.